Say the word rectum. Rectum. Now the most difficult word of all. Say anus. Anus. Say, I will not die from fear. I will not die from fear. And I will not die from embarrassment. And I will not die from embarrassment. And you guys, that is what's going on right now. Okay? Because of these words. And the reason I started, kind of start my talks off like this is that my dad grew up in Compton actually, and he's one of the reasons about MLK because when he was younger, he almost lost his leg trying to go down to USC because they didn't have a hospital here. He then became the head of the Department of Social Services and actually helped to get MLK up and running. My wife currently works at MLK. My grandmother, my uncle, my grandmother just passed, but my uncle is right around the corner, so that hospital is very near and dear to me, okay? And it's very important. So, what I'm saying is that my dad is a very educated person, but I would go down and I'd sit at the dinner table and say, hey Dad, everybody wants you to go into plastic surgery when you're in med school, right? Everybody thinks you can hook them up for free and all those kind of things. So when I finally say colorectal, my dad would say, hey man, I'm eating dinner, don't say that. I don't want to hear about rectum, but that's the problem, is that it is just literally a part of the body. We have to know that we need to be able to talk to our families, we need to be able to talk to our brothers, our significant others in the street about these disease processes, especially when it's so preventable. Slide, please. Or do we have a remote to change the slide? Oh, okay. All right. So, colorectal cancer is the third most common cancer in men and women, okay? But it's the number 2 cancer killer in both. So it's the number 2 cancer killer, yet I'm going to tell you how it's preventable. And this is what's very interesting is, when I say the number 2 cancer killer, you have to know that this is in America. Now, what's very interesting is that I just got back last year. We went on a medical mission to Uganda. Now, in Uganda, I did 40 surgeries in 8 days. And you know what I did not operate on? Colon cancer. Okay, Uganda, Nigeria, and a lot of these sub-Saharan African countries, there's not colon cancer. It literally makes up like 0.5% of what they deal with. And this is amazing because, in America, African Americans, we have a higher rate of colon cancer, but Africans actually have, and Indians actually have one of the lowest rates of colon cancer. When you look at Japan, so Japan has a high rate of gastric cancer. But when a Japanese family moves to America, then they have a child. That child, they fall into the same cluster of colon cancer as we do in this country. So we do know that a lot of these diseases, there's a lot of, we have our genetics, but genetics make up only about 8% of colon cancers are genetically related that we know of today, okay? But we do know that a lot of it has to do with environmental factors that we can help control. Some of them you can't, and some of them you can. Slide, please. Again, these are the stats. So it's about 150,000 newly diagnosed cases and about 50,000 deaths will occur. Slide, please. So I always like to say, I want everybody to know we start from the ground up, or I should say the bottom up, okay? So what is the purpose of the colon? Now, usually when I ask people that, people say to make poop. That's not actually the purpose of the colon, okay? So the colon right here is about a 5-foot tube, all right? And this is the actual colon. This is your appendix. Everybody's familiar with appendicitis. This is your appendix. This is the colon here, okay? And this is the rectum, all right? So the colon's job is actually to reabsorb water. After your kidneys, it is the second thing that reabsorbs water. It's very important, okay? And then you have the rectum. Now the rectum's job is to hold what's left until a socially appropriate time to get rid of the waste, okay? That's the rectum's job, all right? Now people always ask me, and that's the truth. People always ask me, they ask every colorectal surgeon, why would you go into colorectal surgery? Do you have something wrong with you? So I always say that you have to be the smartest person in med school to go into colorectal surgery, because I want you guys to think about it. That's the colon, this is the rectum, and this right here is the anus, okay? The anus, there's nowhere else in your body that can differentiate between a liquid, solid, and gas. Now, one other place, it's the smartest place in your body, thus I went into colorectal surgery, okay? All right, so that's the purpose of the anus. The anus lets you know whether you have to pass gas, whether you have diarrhea, whether you have to have a regular bowel. That's the purpose of anus. Slide, please. So cancer in and of itself, okay, so this doesn't matter if I'm talking about colon cancer, lung cancer, breast cancer. Cancer is the growth of abnormal cells, okay? These cancer cells basically invade and damage normal tissue, and they actually outgrow its blood supply. So I had a 40-year-old woman who was diagnosed with colon cancer. She's doing great right now. She's about 48 currently. She actually came up with a company. You guys have seen these shirts that say, gastric, CK, cancer, it's just stupid. She's actually, so she came up with that because that's what everybody says when they get diagnosed, but cancer is stupid. Cells are stupid. They basically lose their ability to know when to stop growing. Like the reason I'm 6'2", the reason my hands are this length and not this length is because my cells knew when to stop growing. Your cells lose that capability, they lose that capacity, and that's what cancer is. And so colon rectal cancer are cancers that start in the colon and the rectum. Slide, please. So we don't know the causes of most colon cancer, rectal cancer, and we do know that only about 8% are genetic that we know of right now, okay? But this is where the power comes in. The most important thing we know is that most DNA changes are actually related to our lifestyle, all right? And this is what's very important. This is, how do we know this? Some of it is what I talked about earlier about when people move from country to country, they start eating different kind of foods, okay? So what's very interesting is that I'm very honest in all these talks, okay? Because I have been preaching for years about, eating a certain amount of fiber, and I'll talk about why, and not eating a lot of red meat, but I didn't necessarily practice what I preached because I love barbecue. God, I love barbecue. I love barbecue, and I used to love KFC, all right? Now, those days, well, I still love the smell, but I don't know because I try not to eat it, you know what I'm saying? But here is the issue, okay? When I say dietary factors, the way that let's take red meat, for example, okay? So we've known, and physicians and medical professionals have known for a long time that red meat is not good for you, okay? The World Health Organization finally last year published it, that it is an actual carcinogen. It's actually a risk. It can cause cancer when eaten in large quantities. The reason is when we break up red meat, we break it up into something called a nitrosamine, which, long story short, is a pro-carcinogen, something that pushes cancer, something that's pro-cancer, something that helps us develop cancers, okay? So I eat red meat maybe once every 2 months, once every 3 months. But what I'm here to tell you is that some of the power of this is that if you eat red meat 4 times a week, if you just try to drop that, you try to eat less red meat, that will in turn help. The reason I don't eat a lot of red meat anyway is because my parents just never ate a lot of red meat, okay? They didn't know why, they just didn't like it, but there's actually a physiologic reason not to do that, okay? Those are factors that we can change. Slide, please. So, in terms of the factors that you can't change, and this is what I kind of break it down to, things we can change, things we can't change. We can't do anything about our age, right? I mean, like, my dad always says it beats, what does he say about getting old? He goes, it beats the alternative, right? We think, right? We don't know. But in terms of age, now this is interesting, and this slide has changed. I'm actually in the process of changing some of these slides. Most colon cancer still does occur in this country in patients over the age of 50. But I don't know if you guys have read, I just did an interview on NPR about a month and a half ago. There's a big study published that there's been a 12-fold increase in colorectal cancer in millennials. So for millennials, I have this whole talk called Colorectal Cancer and the Red Hot Cheetos Diet. Okay, because, so we've seen that one of the biggest reasons, this is why I'm really interested in talking to you guys about this, is that processed food consumption here is at an all-time high. What I like to say is that America, I've been all over the world, America is, I'm not going to say anything about what's going on politically right now. It is the best country in the world. Hopefully it'll stay that way. But anyway, it is the greatest country in the world, but we have a lot of food. But a lot of our food is garbage. Okay, a lot of our food is garbage. And that's the problem, is that for the first time ever, our garbage food is actually cheaper than healthier food. Like it used to be, growing up, that used to say, well, it is still cheaper to go buy vegetables and everything and cook for the week than go to McDonald's. It actually is not now. Because actually you can eat garbage every day for like 99 cents. Multiple, there's these, and that's the truth. And so that's hard, because how do you tell a family, people work all day, kids are crying, they're hungry right away, things of this nature. And even when you're not there, there's vending machines at schools, and so it's a battle. But that is something that we can do. We can't change our age, but we can change some of the dietary things that we eat. Now, what's interesting is that in terms of age also, when it comes to cancer in this country, African Americans are first in terms of who gets colorectal cancer, then Caucasians, then Latinos. But what's interesting about our Latino brothers and sisters is that they get cancer younger. So Puerto Rico actually had a pretty neat system before they got this horrible hurricane, is that they were actually doing colonoscopies on everybody at 40. Okay, they started a program to do that, because when Latinos get it, they actually get it younger. Now what's interesting is that we work a lot, and I think I saw the American Cancer Society here, work a lot with them, and they've actually now just changed their recommendations. It's been 45 for African Americans for colonoscopies for a while now, but a lot of primary care docs did not know that. But now it's 45 for everybody. And so what we're looking at is trying to move the needle for African Americans to 40. And so I'll talk about some of the things you can do to get those colonoscopies at 40. Now, something else you cannot do anything about is your race. So African Americans are more likely than any other racial group in America to get colorectal cancer. But like I was saying before, in Nigeria and Uganda and a lot of these other countries, it is the lowest, like in the world, it's the lowest. So if our genetic makeup comes from that, what are we doing here that's different? And so one of the biggest things that they're looking at is some of the dietary things. Like they eat a lot of curcumin in Nigeria. There's a lot of hot and spicy food in Nigeria. There's a lot of physical activity. Because it's a third world country still, there's still a lot of physical activity. A lot of them aren't sitting around. A lot of people working, moving, and things of that nature. Not a lot of obesity. So these are all things that while we know that it matters, we're just trying to figure out exactly how it matters. Next slide. So in terms of African Americans, again, it's the higher incidence, advanced stage of presentation, and decreased survival. But the good news is, for the first time 2 years ago, our incidence leveled off. It was the first time that there had not been an increase in the incidence since they were keeping these stats. We were always going like this. Some people think it's actually because of Obamacare that more people had gotten screened than any time before. And so that's one good news, a little bit of good news I do have to report, is that our incidence has leveled off. It's still higher than everybody else's, but it's not going up. So that's something that's good. Next slide. So now these are the factors that I really try to harp on. These are things we can do things about, okay? Now, in terms of being physically inactive, right? The whole thought of why obesity in and of itself promotes cancer of all types is that when you're obese, you're in a chronic state of inflammation. Basically, your body's always fighting something, okay? And so, like in a layman's terms, meaning that then if you get cancer, your body doesn't have enough energy to fight that in addition to some of the inflammatory effects that obesity has. So being physically active, you guys, is very important. But you know, the hardest things I do when I tell patients, and I think a lot of the physicians feel the same way in the room, is that, you know, I fight insurance companies a lot. I have to fight health systems a lot. And you know, the least thing I hate to fight, but I spend most of my time fighting. When I say fighting, I just is my patients, okay? You know, it's funny, our stereotyping, when I talk about African American stereotype, I think we have one of the most wrong stereotypes about us, okay? People think that, you know, aggressive and this and that, but actually, unfortunately for us, whatever our doctor says, we just do. And that's really the truth, is that whatever you say, doc, whatever you say, doc. When as you guys know, I'm chief of the colorectal cancer program at Cedars, and I had it was a very cultural kind of awakening when I was there. When I first got there, my black patients, I could say anything. And they'll say, yes, doc, we're happy you're here. Yes, doc, we're doing it. Now, luckily, I care, and I'm pretty learned, you know, so I'm saying the right thing to do. But I remember my Jewish patients, when I first got there, they would come with a list, and they would just be all these questions. And at first, I remember leaving the room, and I'm like, are they just saying that because I'm young? Because this is about 10 years ago? Or is it because I'm black? But no, that's cultural. Like, when they come to an appointment, they have questions, they've done research, they've done all of these things. And this is so important. This is something that I definitely picked up. I have 2 little daughters. And I train them now. We go to the doctor's appointment. What do you want to ask your doctor? What do you want to get out of this appointment? And then my 11-year-old scared me. She was like, Dad, you may have to step out the room because I want to ask her something else. I said, whoa, whoa, whoa. So I made my wife go with her because I didn't know what that was about. But I'm trying to train them because, you guys, we're a team. You know, the real point of this talk, and the reason I had to jump up because you were stealing thunder over there, is the whole point of this is not really colorectal cancer. It is being your own advocate. Okay? Yeah, we all love patients that will just come in and say, yes, doc, no, doc, because we got to go. Doctors want to help you, but now a lot of HMO docs have to see so many patients in a day. They love a patient like you, right? You just sit there, you say yes, and you go. But that's our problem. That's not your problem. Okay? And I encourage everyone. Whenever you're going to go, I don't care, to the dentist, wherever you go, even the children in the audience, you guys should know my blood pressure, I know that's a problem. So you take your blood pressure. Is my pressure better? Say it's not. Well, doc, what's the plan? Well, what if that doesn't work? You need to have a set amount of plans. You guys need to be your own advocate because you need to know your bodies. You need to do all that because there's 1 million patients. But there's only one of you, right? And so it's your job to care about you more than I care about you, right? And so that's very important. And if you do that in a nice way, which of course you will, the doctor will appreciate it. It's really a team. You know, that's how I look at medicine. It's a team approach. I can only tell you what I think is best from the research and everything, but I have to know you. I have to know what your expectations are, what your expectations of care. Do you have a family support system? If I have to unfortunately give you a colostomy, do you have somebody who is there to help you? but it's a team approach. Okay, there's no more of this dictating care to each other. The internet can teach everybody a lot, and so we can at least have an educated conversation together, and that's what's very, very important. Alrighty, so in terms of eating a diet high in fat, especially red meat. So I hate to tell you this, everybody, but pork is not a white meat. Okay, so pork, lamb, beef. Okay, this is a World Health Organization. All of these are pro-carcinogen type foods. Okay, now I'm not telling you to stop cold turkey. You know, after this talk, sometimes patients will come with us and say, "Doc, that was great. I'm done with meat." Those are people who are going to be eating meat next week. I mean, instead of that, you can't. You know, you have to be realistic, right? We have one of the dietitian nutritionists back here, and she helps do this diet for prostate cancer, which I'll talk a little bit about. You know, we do some prostate screening and everything at Cedars, but there's a whole diet that Dr. Freeland, she has come up with that helps to prevent and also help to stop recurrence of prostate cancer. Okay, we're trying to do those kind of things for colorectal cancer, but the key is reduction. If you eat red meat every day, just try to go like 3 times a week. Just try it, because what you'll realize that you will actually feel better. And that's what people don't understand. You feel better. It's hard to hear that until you actually experience it. But just in terms of eating a lot of that red meat and a lot of fatty foods, that in and of itself is a cancer risk. Now, all colon cancer starts as polyps, these little growths, okay? Polyps have no symptoms. They have no symptoms at all. The only way you can actually see polyps is when you get a colonoscopy, you end up removing it before it becomes a cancer. But all of these cause, all right, in terms of smoking, make sure that is, I mean, everybody knows. Okay, smoking can cause, you know, from lung cancer. It basically dampens your immune system. You can't fight anything other than, you know, whatever the phlegm in your chest is. And so it actually helps to. If everybody knows, fiber actually is great. The best source of fiber, and I always tell people that the first time is the best time. So I'm a pretty busy guy, but like I said, I'm practicing what I preach now, and I'll tell you guys why I'm doing this now. But we need 20 to 25 grams of fiber in. Average American gets 10 grams of fiber, and average vegetarian American gets 12. But the vegetarian American still loves mac and cheese and French fries. Okay, fiber, I'm talking about like fruits and vegetables. So I love berries. Okay, even if you're diabetic, you can still eat berries because berries have a lot of fiber. So blackberries, blueberries, raspberries have between 7.1 to 7.5 grams of fiber per cup. So, and the best thing about berries is that even frozen, they hold their nutritional value. Okay, so a lot of times, you know, because fresh berries are expensive. I have a Costco membership, so it's a little cheaper, but they're still more expensive than frozen. But frozen berries do the same thing. I take 2 cups of that. Almond milk only has 40 calories per cup. That's right. And then I do a protein powder, and then I blend it. If I have fresh berries, I put ice in there. So I walk out of the house every day with 14 grams of fiber and about 25 grams of protein, and that actually keeps me from eating lunch most of the time because you're kind of full. And it's very good, you guys. That's the most delicious way to get fiber. Metamucil, you can add that on there too. Metamucil is great. Prunes are the best. Okay, I did not realize, you know, prunes. I grew up with my grandmother. I'm like, oh, prunes are for old people. Prunes are actually tasty. If you ever get a good prune, prunes are great. You know, don't sleep on prunes, right? Prunes have 13.76 grams of fiber per cup. So prunes are really good. Now, why is fiber important? So fiber is not absorbed in the body. Fiber is a natural thing, but fiber goes straight to the colon. It helps to hold water in the colon. It helps you do something called decreasing your colonic transit time. Your colonic transit time is the time that waste gets into the first part of your large intestine to the time you expel it, okay? Now, if you want and pardon the pun, a cheap, dirty way to figure out what your own colonic transit time is, it should be no greater than 8 to 22 hours, okay? And you eat beets. I want you to eat a plate of beets. From the time you eat that plate of beets, you just calculate how long it takes for you to have a bowel movement that you feel like, oh my God, I'm bleeding. Okay? Because your stool will be red. Your stool will be red. I get that call about once a week. Somebody's like, diet. I'm like, what'd you eat? Oh, okay, blueberries, beets. But that's how you guys know. And that's very important. So that's how you know how quick your colonic transit time is. Why is that important? Because waste sitting in your colon, okay, and the processed foods and the carcinogens sitting in your colon, that is actually what can cause colon cancer. Okay, so you want to decrease your colonic transit time, and that really is, instead of me ordering $1 million test, if you eat a plate of beef, you can calculate your own. Okay, and so that's something that's very important. So that's what fiber does. Fiber helps to decrease that. Water. You want to drink so much water that your colon reabsorbs what it needs, but you still have enough left in the colon so you can have a soft, easy bowel movement. That also helps to prevent a lot of other problems I take care of, such as diverticulitis, such as hemorrhoids, things of that nature. Okay, next slide, please. So this is a normal colon, and then this here is a colon with the flat polyps, and the colon with the pedunculated polyp, okay? All of these polyps can cause cancer. Now, the reason we worry more about flat polyps is that if a polyp grows, if this is the lumen here, you want it growing out like this, it's easier to remove, but also it's a less risk of, if it's a cancer, you can actually see it. If it's a flat polyp, you worry that it's going into the wall. So you have to make sure you're very experienced in terms of removing that. And that's why that one has a higher risk of cancer, because a lot of times you don't see it as easy with colonoscopy. Now, don't get me wrong. Colonoscopies aren't perfect by any means. There's actually about a 6% miss rate, meaning that they've done a study in Canada where I do a colonoscopy, and I know as a colonoscopist, somebody's going to come right behind me and do it again. And even knowing that somebody else is going to do one right after, which means that I was very careful the first time, right? Because I don't want to be showing up. There's still a 6% miss rate. So it's not a perfect test. But the key with a colonoscopy, in my opinion, despite all these other tests, is it is preventative. Okay, this is the only test. So my mom passed from about a month before I graduated from med school. My mom died of breast cancer. Long fight. She was awesome. 10 years, meds to the brain, meds everywhere. And she was a trooper. Okay, had a mammogram, no cancer. Doesn't prevent it. Okay, colonoscopy is the only test, and actually I take that back. There's one other pap smear. When you get your pap smears, you see changes in the cervix. You can take it out before that becomes cancer too. But these tests are also they're screening, but they're also diagnostic and preventative at the same time. So that's what's very important. That's what's very important. So that's why I kind of harp on that versus some of the other stool tests, which can find blood, and they're not sensitive for polyps, but they're actually they can find cancer. And I'll tell you why, as a colorectal surgeon, why that's still an important test if you cannot get a colonoscopy. Next slide. So, early detection can help find and remove precancerous polyps. If you do limiting your high-fat foods, getting your regular activity, and eating a lot of fruits and vegetables can also be very helpful in prevention of colorectal cancer. Slide, please. In terms of signs, okay, so the reason that colorectal cancer, one of the reasons why it's such a killer in this country is that the signs are very nonspecific. Now, how many of us have had a little, change of bowel habits from time to time, right? Everybody's been a little constipated sometimes. Everybody's had a little diarrhea. All of us have had a little bleeding before. But then how do you know that you don't rush off and it's not cancer? Well, the key is, number one, knowing your bodies, but looking for patterns, okay? People always say, like, when I wipe, should you look? Yeah, you should look. You should just look. Every time you should wipe, know a vicious difference to you, and that progresses. If your stool is black for like days, that's important. For like a couple weeks, that could be bleeding, okay? If you usually go to the bathroom every single day, clockwork, and all of a sudden over the course of a month and after going every 4 days, and you haven't changed anything else, but that's important, okay? Those are the times you need to be seen, okay? It's not necessarily once or twice, but it's when there's a pattern, when there's a change in your pattern. That's very important. Next slide. In terms of colorectal cancer, all right? The reason I went into this field is because, I always wanted to be a superhero growing up, and then you realize when you jump off the roof a couple times, you break your arm, you can't fly. You need to realize that there's another way to save people. I actually went into this field because most people I operate on, man, it's the greatest. They live. They live long lives. They don't die from this, okay? Which is why it's incongruous that this happens and that so many people are dying. The benefit is, and this is the truth, you guys saw that map that he showed. We're so lucky we live in Southern California. And that's the truth. I mean, I went to Morehouse undergrad, and in the South, in the South, that the chance of if you have colon cancer, even one that's high up, not rectal cancer, you have a 50-fold chance of getting a permanent colostomy bag for the same operation that, for me, you only get an ostomy if maybe it's this close to your anus. Okay? Now, it's not that we're what's the word? It's just that I think that the level of care, the level of everything here, the level of racial disparity, all of these things is a lot better here than in the South. That's true. But also on the other side, their level of obesity is a lot higher than us. There's a lot of different reasons, but there's no reason here that we can't get colonoscopies. You could throw a rock. You could literally walk out here and throw a rock and hit somebody like me. A colorectal surgeon, a GI doctor, somebody. And with a little bit of knowledge and the knowledge that everybody, like you guys, I mean, you learn a little something, but the fact that you're here, you care, right? But it's when you guys take this out to your community, and like that's what I loved about what you guys were saying with the community liaison, right? It's because it's like each person, it's like there's 50 of you in that chair. You know, and that's really the key, is that to basically take this out, even if you said at dinner, you said, hey, I had my colonoscopy today. I had 4 polyps. I had 5 polyps. Things like that. That's very important to tell our family members so you know your family history. Next slide. So, once again, screening is very important, and it's really so that twofold. Number one is you can detect cancer early, but even better, you can prevent it. And that's prevention is with the colonoscopy. And I'm rushing through a little bit. I'm trying to be on time. Next slide. So there's tests that find polyps and colorectal cancer, and then there's tests that just find cancer. Slide. So, slide. The tests that find mainly cancer, okay, are the FIT tests and the stool DNA. Now, this first test, this fecal occult blood test, is not even recommended anymore, you guys. So we used to do this, you know, doc would have these hemoglobin cards, we do a rectal exam, we put on the card and say, you're good to go. Here's the issue. Or you should worry, you have cancer. The problem is, in order for us to do that test, it should be 3 in a row. It should also be, you have to stop like 12 foods that I give this talk and I always still forget the food. It's like honeydew melon, tomatoes, you can't have meat. These are all things you have to stop for 3 days that we never had you do. So in some ways, we used to say, well, it's better than nothing, but in my opinion, actually it's worse because it gave you false hope that everything's fine. False sense of security. Okay, false sense of security is worthless. That's worse. Okay, so FIT testing is a test that they're really doing this a lot at Kaiser now. It is good at finding cancers early because it looks at human blood changes, but it doesn't because it's not good at finding polyps, okay? Stool DNA test, that's the Cologuard test, right? That's the one that you send it in. That test is really good at finding cancer, okay? But that's not the point, in my opinion, okay? That's not the point. Now, I argue sometimes when I speak on behalf of the American Cancer Society because they do say, and they're right, that the best test is whichever one that a person will do. The only problem with that is that we tend to be offered the stool tests more than everybody else. So there's this study by Dr. Stain who actually, anytime there's a racial disparity, they always, between African Americans and Caucasians, they're always like, because white people have money and black people don't. So this is the first guy that actually looked at rich African Americans versus rich Caucasians, middle, poor, and found that even the rich African Americans were not offered colonoscopy as much as the Caucasian counterparts. Now, is it some vast, conspiracy that doctors even hate us and all that kind of stuff? I'll tell you what it probably really is. It's about being comfortable with your patients, okay? So I can tell you, every single male, especially every single brother that comes in to me and I'm like, it's time for a colonoscopy, I'm like, doc, I don't want you sticking that in my butt. That's what everybody always says. Like even my buddies, I'm 43 years old, okay? I got all my boys, right, not me, and not me either, right? But I'm the one who says, look, guess what? I don't care, you gotta do it. Now, to tell my patient for you another test because it's not good. I'm not gonna say, oh, okay, well, don't do that. But that's what it really comes down to. Being comfortable, I don't care what race your doctor is, you have to be comfortable with the doctor, male or female, and the doctor has to be comfortable with you, okay? Sometimes I got my kids, medicine doesn't taste good. Sometimes you gotta give people what they need, not what they want, right? And so I'm to the point where there's certain, sometimes I felt so strongly about certain things that I could not be the patient's doctor anymore because it just wasn't right. I'm not gonna do something I don't believe in just because that's what, you refuse to get a colonoscopy. I'll bring your mama in. I'll bring your wife in. I mean, that's how I really get everybody. I just go to the watch. You know what I'm saying? But that's the truth. But that's the truth, right? Is that you have to be comfortable. So that's what I think it really amounts to, is that you have to be comfortable. And a lot of times other doctors are, if somebody's like, doc, I don't want you sticking anything in my butt, they'll be like, okay, just do this test. And that's not necessarily the best thing to do. That's really what that study kind of was coming down to. I'm sure there's some other issues with that also, but that's part of it. Next slide. We got one more slide. All right, so the advantage of a colonoscopy, and I do not own stock in colonoscopy, by the way. Okay, I'm just letting you guys know this is what the colonoscopy is: highly sensitive, highly specific. You're able to actually remove the polyps. Now, if it's normal, you guys, you have to remember that there's national guidelines. Okay, so national guidelines say it's normal is every 10 years. Okay, here's the problem. I can do a perfect colonoscopy on you, no polyps, like people can come, 5 docs can come behind me and there's no polyps. If I wait 10 years, you can have a cancer in 10 years. It takes from time 0 to 7 years to go from nothing to a cancer. Okay, what's the point of this test? Prevention. So that's why colorectal society, like we all have our little societies, right? Colorectal society recommends every 5 years. Even American Cancer Society says between 5 and 10. Now, a lot of HMO systems like Kaiser strict 10. okay? Because, and they're right, if you wait 10 years, 92% of people will not have a cancer by the time you do it again. And that's great. But if you're in that 8%, that sucks. You know what I'm saying? So that's the hard part, is that you have to remember that guidelines are also meant to take care of the largest number of people, but there is a cost to healthcare. But once again, that's that problem. That's why you have to know yourself, because if you advocate for it, you will get it. So the guideline used to be, example, he comes to a lot of these and he hates it when I do this, but he's not here right now, so I can tell this last story. So my dad said he was getting a colonoscopy. I trained at Harvard, UCLA, and part of it we rotated at Kaiser, Harbor City. I grew up with Kaiser system, Kaiser West LA, right here. Kaiser Cadillac, as we call it. Yeah. So my dad's been telling me about a colonoscopy. I didn't think much of it, and all of a sudden, he comes home and he's like walking like this, and he's like, "I can't believe you do this for a living." And I'm like, "I can't believe you made me get that." He goes, "I had a colonoscopy." I'm like, "But Dad, you just drove yourself home." "No, you didn't." He goes, "Yes, I did. I had a colonoscopy." And I'm like, "What are you talking about?" I'm like, "Dad, did you go to sleep?" "No." "Did you have an anesthesiologist?" "No." So basically, he had a flex sig, because one of the guidelines used to be is a flexible sigmoidoscope and a fecal occult test. Okay, I was like, "Dad, man," and to me, a flex sig is one of the biggest reasons people don't get a colonoscopy, because you're awake during that test. So I had to fight. I called his doctor. I'm like, "Man, this is ridiculous. He's 55 years old. He needs to have a colonoscopy." He goes to get his colonoscopy, and literally, so a flexible sigmoidoscope stops about here. It stops at about the descending colon. At the splenic flexure, 4 centimeters away, he had 5 polyps. And let me tell you why this is so important. He had 5 polyps. Okay, they removed all of them, right? Now, I throw it in his face. I saved his life on a regular basis. Let me tell you, but this is why it's important. He threw it back at me because he saved my life. So, because he had so many polyps, okay, I'm 43, I'm turning 44 in November. Last year, I had a colonoscopy early. Now, I'm supposed to wait till I'm 45. Okay, this is what the guidelines say. African Americans 45. Okay, and 2, I had one because of my family history that I knew from my dad, and I had a high-grade dysplastic polyp in my cecum. So if I would have waited till even this year, it would have been a cancer. It would have been a cancer. So my dad's like, "I saved your life." I said, "Yes." But you guys, this is how it's really important. And this is real-world, life-saving information, you guys. You are not a price, okay? There's things I can talk to you offline about how you can colonoscopy even if insurance will pay for it. There's certain code words you have to say that we have to do it. But I really believe in this. I really believe in it. And the key is being your own advocate. Knowing that what are you doing on your end? Are you eating a lot of fruits and vegetables? Are you drinking your water? Are you exercising right? And then what are you doing to prepare for your appointments to make sure I'm doing everything on my end? Whether it's diabetes, whether it's hypertension, whether it's cancer prevention, you guys, you have to realize that, we really, and it's all corny, but it's true. You only get one body, right? And if you don't, the last thing is that if you're having trouble getting somebody, so my stepmom, ironically enough, is 62 and had never had a colonoscopy. I give about 9 to 10 of these talks a year. And my own stepmom wasn't getting the colonoscopy, right? Now my stepmom has adopted 2 little kids. And this is how I got her. I was like, "Look, I'm not taking care of her." My stepmom, they're kind of my family now. I'm not taking care of her. You have to be around to take care of these kids. I was like, "Do you love them? Do you love them? Because you don't do it for you." I tell guys that you love your wife, you love your family, do you love your kids? Do it for them. And then they're like, "Well, they can live without me." Well, no, that's not the point. They won't know what they have unless you get tested to know what you have. And they won't know whether or not they need to get tested earlier. And so you guys, the whole point of this, once again, is just remember, you are your own healthcare advocate. You got to be prepared for these doctor's appointments. In real community research, when you see people, doing real, in our community, doing research that is validated and true, participate in that. Because that's the only way that we can, help make ourselves better and help make our community. Guys, so much.